Welcome everyone, and thank you for joining the deVeber Institute's emergency lecture series on Bill C-7 and palliative care. We are honored to have three esteemed doctors with us tonight who will be speaking about both of these topics. My name is Zoe Stewart-Bedard, and I am the Executive Assistant to the Board of the deVeber. Before we begin our presentation, I want to go over a couple of the details. So first off, this is a two-day lecture. If you haven't already registered for tomorrow night, we invite you to do so. The registration link is available on our website, which is www.deveber.org. To best view the lecture tonight, we ask you to switch your monitor to speaker view. You can do that in the top right-hand corner of your screen. There will be a question period at the end of the lecture tonight. Please submit questions during the presentation so that we can begin right away. We will address as many questions as possible, and any that we do not get to tonight, we will ask the presenters to reply to, and we will send those replies out to all in attendance tonight. To submit a question, you can use the Q&A box that is at the bottom of your screen. We will begin in just a minute.
Good evening, I'm Martha Crean, and I'm representing the Board of Directors of the deVeber Institute. Thank you for joining us tonight. We hope you're all well. For almost 40 years, the deVeber Institute for Bioethics and Social Research has been asking questions about current bioethical human life issues and seeking answers based on the evidence of research and experience. Our institute's name honors the late Dr. Barry deVeber. He was a pediatric oncologist and a pioneer of Canadian palliative care for children. 1 year ago today, I think it's fair to say that probably not one of us could have predicted that we would be in the situation we are in. I don't think any of us could have foreseen the remarkable redirection our lives would be taking due to the COVID-19 pandemic. Extraordinary social solidarity has been called for during this time and continues to be to protect human life, particularly the elderly and the most vulnerable. And simultaneously, we are called and have been doing our best to respect and appreciate the frontline workers, especially the care given by healthcare staff. In the midst of this mobilization to protect human life is the much less discussed but increasing practice of assisted suicide, legalized 4.5 years ago in Canada as MAID, medical assistance in dying. Tonight and tomorrow's emergency lecture on Bill C-7 and palliative care will address the imminent change to this law as Parliament and the Canadian Senate hasten to a vote. This vote will have major implications for Canadian healthcare providers, for patients, and families. We are very, very grateful to the three speakers we have tonight and the 4 speakers we will have tomorrow night, who will help us to deepen our understanding of the situation and to focus and refine our points of view with information. First speaker tonight is Dr. Leonie Herx from Kingston, and she's the head of palliative care medicine at Queen's University and the immediate past president of the Canadian Society of Palliative Care Physicians. Tonight, she'll be speaking on palliative care and bringing us some understanding of where Bill C-7 is. Thank you, Dr. Leonie Herx.
Thank you to the deVeber Institute for the opportunity to be with you tonight and to be part of this panel and important discussion at this critical time in Canadian history. I've been involved in education and policy development related to the intersection in palliative care and MAID for the past 6 years since the Carter case in 2015. I've written extensively and spoken nationally and internationally on this topic, most recently as an expert witness for the parliamentary committee studying Bill C-7 in both the House of Commons and the Senate. During my remarks this evening, I'll cover 4 key objectives. The first is to review what palliative care is, then what MAID is, provide a brief overview of the current MAID legislation under Bill C-14 and the changes that are proposed under Bill C-7, and discuss the various aspects of these and their impact on palliative care. To start with, what is palliative care? Palliative care is care focused on improving the quality of life and symptom management for those living with life-threatening conditions and their families. It does not intentionally end life and is internationally recognized as a practice distinct from MAID. Both the World Health Organization and the International Association for Hospice Palliative Care definitions of palliative care speak to 3 core components. The first is a core philosophy that affirms life, that sees dying as a normal process and focus on living well until natural death. The second is the intention of palliative care, to alleviate suffering, to enhance dignity, and to improve quality of life. The third is the approach of palliative care, focusing on impeccable symptom assessment and management and supportive care for the whole person, including physical, psychosocial, emotional, and spiritual issues. Evidence shows that early access to quality palliative care improves a person's quality of life, enhances their well-being, reduces anxiety, improves satisfaction with care, and in some cases, even helps people to live longer. Despite all of this, the unfortunate reality in Canada is that many Canadians do not have access to the high-quality palliative care that they need and want. Our best understanding is that only approximately 30% of Canadians have access to any form of palliative care, of course with large regional variation. Some of our rural remote communities have almost no palliative care. And overall, only about 15% of Canadians have access to specialist palliative care, which is needed to manage more complex situations. Palliative care has not been deemed a right under the Canada Healthcare Act, and there is therefore no formal obligation to ensure it is adequately funded and accessible at a provincial level. Second, I'd like to talk about what is MAID. In Canada, we have legalized both euthanasia and assisted suicide and refer to them under the banner of medical assistance in dying, or MAID. In MAID, death is intentionally caused by administration of a lethal dose of drug. Death is not due to the underlying illness. In assisted suicide, a doctor or nurse practitioner writes the prescription for the lethal drug, and the patient takes the drug him or herself. In euthanasia, the doctor or nurse practitioner directly administers the lethal dose of drug that ends a person's life, often in Canada via an intravenous route. The overwhelming majority of cases of MAID in Canada are euthanasia. Very few people choose to administer the medication themselves, the drug themselves, So MAID is not palliative care. And another important concept that we don't have a lot of time to go into detail today, MAID is also not the same thing as discontinuing or forgoing life-prolonging medical treatments, such as antibiotics, dialysis, chemotherapy, when those treatments are felt to be futile or the burdens outweigh the benefits. Why do people request MAID? The primary reason that people request MAID, and has been shown to be consistent internationally, is due to emotional and psychological anguish. Most requests for MAID are not due to uncontrolled physical symptoms such as pain or shortness of breath, but rather fear of dying, fear of having pain, worry about being a burden to others, and a desire for control. So far in Canada, we've seen about 20,000 MAID deaths since it was legalized up to the end of 2020. And the number of cases have been steadily rising each year and now account for about 2% of all deaths. Next, I'll give a brief overview of the development of MAID legislation in Canada that we've also heard a little bit about in the introductory remarks. So in 2015, we had the landmark Carter versus Canada case, where the Supreme Court of Canada struck down the criminal prohibition on homicide and assisting in suicide for the purposes of MAID. They then gave Parliament 18 months to develop the legislation. The resulting legislative response was what we now have as Bill C-14, which was enacted in June 2016. Bill C-14 allows both physicians and nurse practitioners to administer MAID. They set out specific eligibility criteria and delineated standards for safeguards to reduce harm. To be eligible, you have to be at least 18 years of age and capable of making your own healthcare decisions. You have to be eligible for publicly funded healthcare in Canada, have a grievous and irremediable medical condition. Death must be reasonably foreseeable. You must have a request that is shown to be voluntary and provide informed consent at the time of assessments as well as at the time of procedure. The safeguards included a mandatory 10-day reflection period, giving people time to change their mind, 2 independent witnesses, 2 independent assessors who determine eligibility, and the capacity, again, as I mentioned above, serves here as well for a capacity at time of request and time of procedure. In this brief talk today, we don't have time to review information regarding the adequacy of safeguards or the monitoring for MAID and how well they've been working under this Bill C-14, but I'm sure that Dr. Yarrow Kotelik will address some of that in his talk tomorrow night. And if you have further interest in this discussion and this issue, my colleagues and I published a paper in the World Medical Journal in April 2020, which reviews some of the concerns with the safeguards around MAID. Important to note is that under Bill C-14, MAID was made a healthcare right under the Canada Health Act and thereby had to be publicly funded and accessible coast to coast. As I described earlier, there is no similar right to access palliative care or other supports needed for living, such as disability supports or home care. Then we come to 2019, where we have a court challenge in a Quebec lower court, Truchon and Gladue. These were Canadians with disabilities who were not dying, but wanted a right to access MAID. The judge in that court case ruled that the requirement for a reasonably foreseeable natural death for MAID was unconstitutional and tasked the government with addressing legislation to address it. There was a large outcry from the disability community with over 90 disability rights organizations and hundreds of concerned doctors writing open letters advocating for the government to appeal the decision. The government did not. And just a note that this is very unusual to let a lower court ruling from one province dictate changes in federal legislation. The government's response to the Truchon ruling, rather than appeal, was to put forward Bill C-7, which removed the criterion for reasonably foreseeable death, but goes well beyond that by removing safeguards that had felt to be important to protect vulnerable persons put in place under C-14. This bill was initially tabled in Parliament in February 2020, but after Parliament was prorogued, it had to be reintroduced in October 2020. The bill passed its 3rd reading in the House of Commons in November, and last week passed in Senate with a number of amendments put forward. The government responded to the Senate amendments last evening by agreeing to accept the eligibility for mental illness as a sole diagnosis through a sunset clause of 24 months instead of the Senate proposed clause of 18 months. And as we heard earlier, the debate started today in Parliament, and we assume a coming vote will be in the next few days. So what are the changes to MAID under Bill C-7? So of course, it removes the requirement for the reasonably foreseeable natural death. And to do so, the government has created 2 tracks. The first track is similar to C-14 for those that have a reasonably foreseeable death. The second track is for those that do not, and includes a person with a disability, chronic illness, and in 24 months, mental illness as a sole diagnosis. First, under track 1, additional safeguards were removed, including the 10-day reflection period, the removal of requirement for final consent, i.e. capacity at time of the procedure, and a reduction in the number of witnesses from 2 to 1, and that one witness can now be a paid healthcare worker. Under track 2, they put in place a 90-day assessment period. They required that a physician be involved who's an expert in the underlying illness, but that physician does not have to be one of the 2 MAID assessors, and that a person has to be informed and offered other treatment options, but there's no requirement for treatments to have been tried or to even ensure that they're accessible to a person. This is also the same in track 1. A person only has to be informed of their options available to them. But the stakes are seemingly higher when a person could have a readily treatable condition and years or decades left to live, but refuse what we would call the medical standard of care and ask for death instead. I know Dr. Coelho will be speaking more about this, so I will leave track 2 for those without a reasonably foreseeable death for her to talk to you more about. Other countries who allow physician-provided MAID outside the end-of-life context have treated it as a last resort when no other options for care remain. Law professors Mary Sharif and Trudeau Lemons and I recently published a paper which speaks to this impact, the impact of the legislation on the standard of medical care. In this legislation, we assert that patient choice and informed consent are dislodging the medical practice of standard of care and will make Canada the only country in the world to make MAID available as a first-line therapeutic treatment. So how has all of this impacted palliative care? I'll only have time to touch on a few things tonight, as I was talking prior to the seminar that we could actually spend 90 minutes looking just at some of the implications for palliative care and its practice and provision. But I'll pick a few things to highlight. The first is that there's been ongoing confusion between MAID and palliative care. I still have patients who come to see me in clinic, even last week, who think that MAID is palliative care. They think that MAID is providing comfort measures while they're dying. They don't understand that it's a lethal injection to immediately end their life. I think this confusion has been perpetuated by euphemistic language, as well as ongoing myths and misunderstandings about palliative care. MAID language itself, medical assistance in dying, is confusing because that's what I do every day when I provide palliative care. We assist people much earlier in their illness trajectory, but certainly during the dying process, and end-of-life care is a core component of palliative care. But we don't end someone's life or hasten their death. I think the government chose the term medical assistance in dying to make it more palatable. In fact, they did acknowledge that the term assisted suicide was stigmatizing and veered away from that. MAID and palliative care have been lumped together under the umbrella of end-of-life care, including by government bodies and ministries of health. Medical professionals themselves have described MAID as, quote, just another tool in the end-of-life care basket. This seems to put MAID on the same continuum as palliative care. However, I've already described how the key core philosophies, intention, and care provided in palliative care are very different than MAID. MAID is not end-of-life care, but rather ending of life, and goes against the core principles and philosophy of palliative care. National palliative care organizations, including the Canadian Society of Palliative Care Physicians and the Canadian Hospice and Palliative Care Association, have advocated that these 2 distinct practices must be kept separate to avoid perpetuating the confusion. The myths that continue to be perpetuated about palliative care are that it already hastens death. Some people think that by giving opioids for pain or shortness of breath at the end of life that we speed things along. Or they wrongly equate the use of palliative sedation with MAID. Even that was continued to be misconstrued in the recent Senate hearings. Opioids and other medications when used in palliative care are titrated carefully for effect and side effect, and they do not hasten death when used appropriately. Palliative sedation is a particular tool used by palliative specialists in very specific circumstances in the last days of a person's life if they have symptoms that are refractory to usual medical measures. It is to be done in consultation with a palliative specialist so that that physician can ensure that all the other options for symptom relief have been tried and exhausted, and that palliative sedation is provided according to standardized guidelines with close monitoring and for therapeutic effect and side effect, as we would with any medication. When used in this context, palliative sedation does not hasten death. What do we know about access to palliative care since the legalization of MAID? Well, the unfortunate reality is that we don't have robust data to draw specific conclusions, but we do have some limited data and anecdotal perspectives, which I will review. We've seen a lack of investment in palliative care resources, and some existing resources for palliative care have been diminished, even though the Supreme Court of Canada and the federal government said through the Carter case and the C-14 legislation that we needed to enhance and prioritize access to palliative care. In some jurisdictions, under the banner of end-of-life care, palliative care is also being used to fund MAID programs. For example, in Ontario, MAID was placed under palliative and end-of-life care portfolio in local health regions, and in some cases, nurse practitioners in the hospice palliative care program were assigned to be involved in MAID provision using the funding for them to do their palliative care role, thereby effectively reducing already limited palliative care resources. In Quebec, we've seen that the number of physicians providing palliative care has dropped since legalization of MAID. Quebec Senator Julie Miville-Deschênes, during the Senate testimonies, stated, "The reality is that medical assistance in dying has been available in Quebec since as early as 2015, but palliative care at home has failed to materialize. Yet the Quebec Act respecting end-of-life care reaffirms the right to receive palliative care in institutions or at home. The Association Québécoise des Soins Palliatifs estimates that 90% of Quebecers at the end of life do not have access to a home palliative care team to provide round-the-clock support." Is there any evidence that a lack of access to palliative care is impacting MAID requests? In their first annual report by Health Canada, published in July 2020, they stated that 82% of those who receive MAID also access palliative care services, and use this to conclude that requests for MAID are not necessarily being driven by lack of access to palliative care. However, the conclusions of this report have been called into question based on the inadequacies of their data to be able to make such interpretations. These were self-reports by MAID providers and lack specific meaningful information on both the quality or the quantity of palliative care and who it was provided by. Palliative care physician from British Columbia, Dr. Ramona Coelho, looked at this Health Canada data more closely and made a different conclusion. In her recent article in Policy Options, she stated that a lack of palliative care is a failure in too many MAID requests, and that an unacceptable number of people who requested MAID received little or no quality palliative care in the months before death. She pointed out how in the Health Canada report, it also shows that 854 people, almost 16%, of people who got MAID had access to palliative care for less than 2 weeks prior to their life being ended. So she proposed that the trigger in those cases for referral to palliative care was likely the request for MAID. And that another 874 people, also around 16% of people, received no palliative care at all. According to Dr. Gallagher, this should be considered a failure of our system, as many of these people may have been suffering for months without access to quality palliative care. Another recent report by palliative care physician Dr. Monroe in November 2020 examined palliative care involvement in patients requesting MAID in their local region, and they also found it to be inadequate. In their study, 72.6% of patients had no community palliative care physician, and 40% had no palliative care involvement prior to requesting MAID. Next, I'm going to move on to palliative care and requests for hastened death and the potential impact of the 10-day removal of the 10-day reflection period. Palliative care clinicians regularly hear requests or expressions of a desire to die or a desire for hastened death. These are often expressions of grief, anger, loss, and despair as a response to a devastating diagnosis or a change in condition. This lament is often a cry for help, but now we see this leading sometimes to a MAID consult before palliative care has even been involved. Many times, this desire to die goes away with support. Dr. Harvey Chachanoff's published work in Psychiatry and Palliative Care demonstrates that the desire to die in the terminally ill fluctuates and often dissipates within 2 weeks. He told Parliament during the C-7 hearings that the 10-day reflection period strikes an important balance, allowing MAID to be requested while protecting people who might change their minds and go on to live many weeks, months, or even years. The removal of the 10-day reflection period under Bill C-7 means that a person could request MAID and receive it on the same day with no opportunity to change their minds. In the most recent Health Canada report I spoke about earlier, in 1 year, 263 Canadians who had requested MAID ended up withdrawing their request. Had the 10-day reflection period not been in place, 263 Canadians may have had their lives ended prematurely who might not otherwise. I have to say that I have a big worry about the impacts of this removal of the 10 days on our work in end-of-life care and palliative care. I'm worried that it's going to increase the moral distress that our palliative care clinicians are facing as they worry about patients who might be getting a wrongful death and feel helpless to do anything about it. I'm almost done. I have 2 more quick things to talk about. I want to talk about the push that's coming about for professional obligations on doctors about a duty to inform all patients about MAID. As I referenced earlier, Bill C-7 places MAID equal to the standard of medical care, even seemingly permissible as a first-line treatment. And there is accordingly a strong push for doctors to bring it up as an option to all patients as a treatment for suffering. If this became a professional obligation on me by my regulatory college, that would mean I would have to suggest MAID to all of my patients in palliative care, every single one, or potentially risk disciplinary action or loss of license. I have many concerns with this. First, if a doctor offers unsolicited MAID as an option, this may be all that is needed to push a vulnerable person to pursue it. Patients take the recommendations of their doctor seriously, and my patients are already made vulnerable by facing a serious life-threatening diagnosis. The Parliament heard many examples of Canadians who felt pressured to pursue MAID or who were directly told by a doctor they should consider MAID when they were not asking for it. And I know Dr. Coelho will be speaking further to this. Furthermore, since MAID is contrary to the core philosophy and goals of palliative care, I would be betraying my core professional values and role as a palliative care physician by having to suggest MAID. How could I maintain my professional integrity and identity as a palliative care physician and in good conscience be able to continue practicing palliative care? I know many other palliative care physicians who have told me they feel the same way. We have already experienced a number of doctors leaving palliative care practice and retiring early due to the pressures and moral distress around MAID. Where would this leave the future practice of palliative care if many more of us felt we had no choice but to leave palliative care practice? Lastly, there's a large push to provide MAID within all palliative care units and hospices across Canada, even though this is counter to the core philosophy and goals of palliative care. Hospices and palliative care units have been forced with losing funding if they don't comply with this mandate. The most recent example of this is the Delta Hospice Society's Irene Thomas Hospice that was forced to close last month. Along with people who want MAID, there are also many people who want hospice palliative care at the end of their lives without fear that we are going to shorten their lives prematurely or provide MAID without their consent. So what does the future of palliative care look like under C-7's expanded MAID regime? Unfortunately, many of us are worried. The reality is that the ability to provide palliative care true to the core goals and philosophy is becoming more difficult in Canada. We see decreased access to already scarce palliative care resources, not an increase. Even though 98% of people don't want to die by MAID. We see decreased access to safe spaces that can exclusively focus on providing authentic palliative care, such as hospices and dedicated palliative care units. We are at risk of losing palliative care professionals due to the increasing moral distress and burnout as the nature of our work is changing under MAID, and even more people may leave the practice of palliative care, especially if it becomes mandated that we have to recommend MAID to our patients. But we always like to be hopeful in palliative care, so I'm going to end on a positive note. We need your help to demand from government that palliative care is funded as an essential service under the Canada Health Act. We need to ensure that basic palliative care training is integrated into every healthcare professional's program. We need to ensure we uphold the integrity of palliative care by demanding from government that palliative care units and hospices can choose to operate without being forced to provide MAID. MAID can be provided anywhere, including in dedicated MAID facilities or units where people who are ethically and morally comfortable with this type of care can choose to work there without forcing others to participate. We need to get regulatory bodies to agree that MAID must be a patient-initiated discussion, and doctors must not be suggesting unsolicited MAID to vulnerable patients. And lastly, we urgently need conscience protection for healthcare professionals so that we are not forced to recommend death to our patients. Thank you.
Thank you so much, Dr. Leonie Herx. You have clarified so many aspects of palliative care, of MAID as it stands now, and of the proposed changes in a very succinct and understandable manner. Thank you very much for your talk tonight. And you are now going to be followed by our middle speaker, Dr. Ramona Coelho, who is going to be speaking and including conscientious objection rights in her talk. Dr. Ramona Coelho is a family physician in London, Ontario, with a specialty in care for patients with disabilities and serious illnesses. We welcome Dr. Ramona Coelho. Thank you.
Thank you very much. I'm going to just try to share my screen here. Okay, very good. Thank you guys very much for having me. I'm a family doctor who works with marginalized patients, refugees, persons with disabilities, men out of prison. And I'm speaking tonight about conscience, the practice of good medicine, in light of the legalization of administered death. I'd like to start just by clarifying that most medicine is determined by medical research and medical evidence. But with MAID, it's not so. MAID criteria is being set by legislation. In fact, MAID is a criminal code exception to homicide and assisted suicide, and the legislative requirements decide eligibility for this medical service. And unlike other things in medicine, which are usually put forth by evidence and study, MAID is being pushed forward by lobby groups. And the question is, what happens to medicine when it is driven by lobby groups or by interests outside of those of good medicine? And the example I'd like to share is one that was shared in Senate. In the 1990s, there was this idea that kind of caught the imagination of the public. People are very concerned about women with breast cancer. There's a very high prevalence of that. And this idea that a bone marrow transplant with high dose chemotherapy versus standard treatment would benefit ladies, would save lives, would be just amazing. And lobby groups pushed, and it ended up being a covered treatment. Insurance companies in the States felt obliged to cover it because of pressure. And after 4 large medical studies, it was shown that this was actually quite harmful to ladies, and that harm was done when medicine was dictated by public opinion, by lobbyists, and other factors. So MAID was sold to Canadians by a lobby group, by Dying with Dignity, as a mercy to those who were terminally ill, for people who were suffering. And we've heard over and over in Senate that there are no victims in this, and that there will be no victims with its expansion. But here's an advertisement by Compassionate Community Care, which lists abuses and asks for people who have stories, who need support, to contact them for comfort. So clearly, there have been abuses. And I'd like to follow this with 2 slides outlining such abuses. So vulnerable patients who choose MAID freely, but because of inadequate care or lack of access to things that they need to live. Archie Rowland on the left, a landscape architect in Montreal, was very happy where he was, and he was transferred to a long-term care center which didn't have the things that he needed, and he felt he was being treated inhumanely. He fled the institution, was brought back, and he died 3 days later by choosing MAID. The gentleman in the middle, Raymond Bonbenet, chose MAID because his room was 30 degrees Celsius. He had to keep his door open to have access to the air conditioning in his long-term care center, but then people would walk in and touch him and take his things, and he felt generally unsafe and preferred to die. The woman on the right, Arlene Rainsborough, wrote, "It isn't depression that makes me want to die. It's the fear of living with inhumane, overcrowded conditions, loneliness, and lack of hope." So I guess that kind of brings forth the question, what kind of choice is this? Next slide. This is more about what Leonie was talking about coercion to die, this kind of suggestion that these patients on these pictures, that they might be better off dead. Candace Lewis on the left, she had some disabilities. She was acutely ill in the hospital, and the doctor came over to her mother, Sheila, and asked her if she thought Candace should have MAID. When her mother refused, the doctor called her selfish and tried to convince Candace that she would actually benefit from MAID. The family left the hospital as they didn't feel safe. Roger Foley, in the middle picture, lives in London, Ontario, and he caught on camera a medical administrator in the hospital offering him MAID because his home care funding was too expensive. And Taylor Hyatt on the right, a lovely young lady with cerebral palsy, became quite sick at one point with pneumonia, ended up in the hospital. And the doctor suggested to her, or asked her, if she'd prefer no treatment over the standard treatment of oxygen and IV antibiotics. And she says, "All the doctor seemed to see was a disabled woman, alone, sick, tired, and presumably sick of living. I would never want a medical professional to begin the conversation about life-ending initiatives as a result of assumptions they make about me and what it's like to live with my disability. Otherwise, I would not feel comfortable seeking certain forms of medical treatment. I want to be seen by a doctor who will care for me as a whole person, including taking my status as a disabled woman into account, who will support me in living and thriving in the only life I have, which is that of a disabled woman." So in these examples that I've shown you over these slides, we can see how underfunding of healthcare and devaluation of the person can bias choice. For underfunding, let's remember that COVID has affected vulnerable communities by furthering financial difficulties, limiting supports, and furthering loneliness. For devaluation, I'd like to share the testimony of Spring Hawes, a lady who has a spinal cord injury, living with that for 15 years now. As disabled people, we are conditioned to view ourselves as burdensome. We are taught to apologize for our existence and to be grateful for the tolerance of those around us. We are often shown that our lives are worth less than non-disabled lives. Our lives and our survival depend on our agreeableness. A choice to die isn't a free choice when our lives depend on good behaviors and compliance. Further, we know from international data where there is legalization of euthanasia or assisted suicide, we have case studies of doctors suggesting euthanasia to their patients when they need a bed. We see high numbers of unreported cases of euthanasia in anonymous surveys by physicians and nurses, especially when it was done involuntarily, that is, without consent. Likewise, it has been documented that on refusing chemotherapies in certain jurisdictions, patients have received information letters suggesting assisted suicide while being refused their chemotherapy. To help people choose death or to offer them death instead of focusing on treatments is an undermining of medical ethics and the practice of good medicine. In terms of this bill that Leonie described so well, that is before government, she described track 1 and track 2. So track 2 of Bill C-7 will allow those with chronic illness to die within 90 days of request without having necessarily been provided treatment. But we know that suicidality in chronic illness and disability consistently across heart attack, stroke, traumatic brain injury, spinal cord injury, peaks at 90 days. That's the timeline to actually get death with this bill, and resolves within 2 years. So just from a medical standpoint of evidence, the timeline that this government created is extremely dangerous in terms of offering death when patients are acutely suicidal. The next study speaks even more to that. Jakova, Ethans, and Smith are 3 physiatrists who did a study where they interviewed 23 spinal cord people who had spinal cord injuries and followed them over several years. And the majority of them were suicidal when they realized they were paralyzed after their spinal cord injury. But despite that, now, none of them would want to pursue MAID. And all of them said they would not have been able to make an informed decision about MAID post-spinal cord injury. Meaning that if they had been offered MAID, most of them would have chose it, despite being told what their future would be, despite having peer mentors, that the reality is that until they had lived it themselves, they could not believe how good their lives would be. Dr. Ethans, in her experience, said acute care doctors and emerge doctors often do not have an informed idea about disabilities and may inaccurately present future outcomes. Dr. Ethans shared that most people with the new spinal cord injury are suicidal, but within a few years, these same people rate their quality of life as the same as non-disabled people, many higher. So being offered death in that early period when they are vulnerable is a failure to understand medical evidence around injury and recovery. On the right is a picture of Chris Cowley. Chris Cowley had a spinal cord injury 33 years ago, and she went on to get a doctorate, to be a professor at a university. She's a wheelchair track Paralympian. She's married. She has 3 children, all after her spinal cord injury. But Chris shared that it took her 5 years to feel great again in the morning, and that if she had been offered MAID in her early years after her accident, well, she might not be here today. On the left is a Maclean's article by Gabriel Peters, Taking MAID Way Too Far. And it recounts a recent true story of someone who had a spinal cord injury, who was in the hospital, who was offered MAID despite her not being dying, so not even meeting the criteria of C14, and she did not ask for it. So for whatever reason, that doctor offered that patient MAID inappropriately when it was illegal. But she herself in the story said she thought the doctor was trying to be kind. So the question is, what's happening here? Why do doctors or healthcare workers, why do they perceive that death could be good for disability? And I think that this is challenging societal presumptions about the quality of life of people with disabilities. So people have said to me, well, Ramona, people with spinal cord injuries, they're young, they can get back to work, they have time to rehabilitate, hence they have a great quality of life, and that's why a lot of them don't want to die. Great. But that idea is still not exactly hitting the deepest that we could go. The truth is that there's an ableism, this kind of systemic discrimination, that people who are disabled are less happy, are less valuable than people who are able-bodied, that I actually think is what leads us to a lot of our presumptions about these people. The stroke community, who are older and often not working post-stroke, also rate their quality of life after several years the same as the non-disabled age-matched individuals. And what about if we take an even more devastating diagnosis of locked-in syndrome? So locked-in syndrome is caused by a stroke to the pons, or sometimes a progressive disease like ALS, where the patient can no longer move their body. They can sometimes blink. Their cognition is intact, but they cannot say anything, etc. And studies have looked at the quality of life in survivors of locked-in syndrome. And the data actually given to us by the patients themselves questions the assumptions many of us make about the state of life that must be intolerable. Surprisingly, quality of life in locked-in syndrome patients is often the same as age-matched healthy individuals. So this whole bill is unethical as it sets out certain groups of people who are often victimized by society, people who are looked down on and seen as less valuable, people who are at risk of relationship abuse and poverty, as fit for suicide completion. So, as I said in Ethan's study, the patients themselves who had lived that experience wouldn't have had the capacity, they said so themselves, to choose MAID. It wouldn't have been a free and informed decision. So what influences choice, and who is going to get suicide prevention and who is going to get suicide completion? Because the idea that this is a free choice, once we look at this, is really not tenable. And there are many factors. There was a recent study in a BMJ supportive and palliative care journal that showed an unexplained 7-fold variation in euthanasia rates across the Netherlands. And we have the same kind of regional variation here in Canada. The rates in BC are much higher than in the rest of Canada. And the question is why? The authors of the study were hesitant to draw conclusions. They said, well, maybe it's underuse or overuse, maybe it's misuse. They didn't want to really blame anyone. But when you look at the different factors that affected euthanasia rates, social cohesion, having volunteer hours and volunteers available greatly decreased the rate of choosing death. The Netherlands Perspective Study confirms that when people are offered death, their choices are influenced by poverty, loneliness, unemployment, relationship breakdown, lack of home supports with their disability. That is, their disability has led to higher rates of social disadvantage that would lead to desperation, but not the disability itself. It is a societal failure to properly help them that is driving their death wishes. And lastly, physician perception, as evidenced by that first study I told you, will likely play a big factor. Does the doctor sitting across the table from you value your life? I share a story of a young patient I had. She had idiopathic heart failure. She became suicidal, sent her to the hospital for admission. The psychiatrist admits her for protection. And the next psychiatrist comes on and writes to me that her suicidal desires are valid and suggested that she be allowed to die. Feeling unsafe, the family drove into London, Ontario, and we came up with a home managing plan. And she survived. And she's not suicidal. She's even had a heart transplant, and she's quite well. But the perception of the two different psychiatrists, one who saw her value and admitted her, and the second one who didn't, is quite telling. I'm going to stop sharing. I'm going to continue talking, but I don't have any more slideshow. So an ethical decision applies to almost every medical act we make. The patient's health is the good that we should always be seeking. We ensure patient safety. We aim to preserve human life. Historically, this has always been the goods of medicine. When we gently provide education about a subject that a patient didn't come to talk to us about, or we refuse antibiotics because they wouldn't be helpful, well, it becomes very clear that it's not the patient's choice that is alone driving the encounter, but rather the physician considering what the patient needs, what is their good. I know Dr. Yarrow Kotelik is talking tomorrow, so I just want to quote him briefly. He talks about how conscience holds a doctor to the highest level of professional integrity that rules could ever do, right? If you had like 100 rules, a doctor's conscience still holds them to a much higher degree in many more scenarios that could never be created by a set of rules. So he says, if a physician would be forced to act against his or her conscience because of some legal instrument, it would weaken the physician's commitment to conscientious behavior in other instances of clinical practice. One day, he can refer a patient to MAID, even if his conscience is telling him that it's wrong. The next day, but now demoralized, he may act against his conscience because it would bring him prestige or power or money, or simply because to be true to one's conscience is inconvenient and hard. A well-functioning conscience is the best protection, the best guarantee that society can have that the patient's and society's interests are well served in our healthcare system. And so that brings us to the heart of the problem that we're experiencing, many of us now in Canada, and that there is no respect for the conscience of the physician. There's pressure to capitulate to the patient's choice and autonomy, especially in the MAID debate. And autonomy has been put out there as like a paramount freedom by certain groups in society, and made lobbyists and even the government has tried to assert again and again that this is a personal decision that won't affect anyone, a choice made in isolation. I think a parliamentarian even said the autonomy of one, a decision of one. If that were true, we would not have to legalize MAID and then try to get society to help make that isolated, autonomous choice a reality. We do not exist in a vacuum, and we are made for relationships with each other, and our decisions affect each other. And looking at autonomy, what of those who are not choosing freely? Those perhaps abused or pressured to die? I pointed out that Netherlands Perspective study and the BMJ article that showed that there are many different factors that affect choice. And these studies outline that choosing to die is often caused by negative social determinants of health. That is the exact opposite of autonomy, and is in fact coercion to choose death. And although I related obvious cases at the beginning, coercion can actually be quite hard for physicians to see in real time. When I started doing home care, which I did for many years, I realized how much I could miss in a short patient encounter in my office. Abused patients can have feelings of guilt and shame, and they can have embarrassment or a loyalty to their family that make it very difficult for the physician to know where that ask of death is actually coming from. And studies from different jurisdictions where euthanasia and physician-assisted suicide are legal have consistently shown, as Dr. Herx pointed out, that the driving force behind death requests is not intractable pain, is not shortness of breath, is not intolerable suffering, but it is fear. Fear of a loss of autonomy, fear of pain, and fear doesn't lead to a free, autonomous, informed choice. Rather, fear leads to demoralization, right? Capitulation, ambivalence, all of these things are what fear does to us. It doesn't lead to us making great choices. So perhaps framed in autonomy, the truth is that there's often a lack of interest in these groups, in these populations that we're seeing singled out as fit for suicide. How much easier is it to kill them via lethal injection than investing in them as a society when people don't perceive that they have value? And are pro-MAID advocates weighing the value of others' lives and affirming their lack thereof? What perhaps started out as an apparent merciful act for a few becomes a value judgment when our society no longer respects all among us as equal. Some advocates of MAID argue that they are doing what's good for the patient. It's not just autonomy, it's also good. They claim that death is good and better for the patient who is suffering and in intractable pain. However, intractable pain is only an issue when the standard of palliative care, when accompaniment and resources are lacking. And underfunding can greatly affect choice. And also the choice of death, while accompanying medical care, home care, disability supports, and livable income are denied, doesn't sound like a good choice to me. So where can a physician who does not think administered death is good medicine fit in Canada? Some of our provincial colleges say we need to leave medicine or retrain. Some of us will burn out from moral distress. Others will retire early or restrict their practices so that MAID is not an option to be offered. Yet as a medical practice, regardless of what we each individually discern, we need to do what we've always tried to do, to instill hope and resilience in our patients and practice good medicine in the face of a terribly unethical legislation. We have a rich history of meaning in accompanying suffering patients, and medicine and patients will always benefit from conscientious physicians who continue to look for creative, unique solutions for their patients' healings over medically administered death, which is easy to met out one by one and always achieves its purpose, which is death. Thank you.
Dr. Ramona Coelho, thank you so much for one thing, inspiring us for what good medicine and good care look like and should be, and for personalizing the situation. We are talking about individuals and the discrimination that can lead to ultimate results that are not in the patient's best interest. Thank you for sharing as a caring doctor today with us and giving us a lot to think about. The third doctor that we're going to have today is Dr. Thomas Bouchard. But before I introduce him, I just want to remind everyone that we're happy to have questions. If you are feeling a question forming in your mind right now, you may type it in and send it along, and Zoe will be able to capture it, and hopefully we'll have time to share some of the good questions this evening. So please go ahead and type in any questions you have, and Doctors Herx, Coelho, and Bouchard will be answering those questions individually or collectively at the end of Dr. Bouchard's speech. So our final talk tonight is from Dr. Thomas Bouchard, who lives and practices in Calgary, Alberta, and where he is a physician dealing with the needs of long-term care patients. And tonight his focus will be on the ethical safeguards for the vulnerable. Thank you very much, Dr. Thomas Bouchard. We're looking forward to hearing you.
Thank you, everybody. And thank you, Dr. Herx and Dr. Coelho, my esteemed colleagues who are very difficult to follow. So speaking of safeguards for the vulnerable, the first thing I would want to clarify is the best safeguard for someone who's vulnerable is a person who cares for them. There are no rules or policies that will ever protect a person like someone who cares deeply for a person. And in order to protect every person who's tempted to consider euthanasia or suicide, is a physician who's willing to meet them in the dark and low moments of their life. And one provocative way that I've used to say this is that as physicians, we should be willing to go to hell with our patients and then provide them with a life-saving hand and lift them back out into the light. So like I was saying, to protect the vulnerable and to protect conscience, the best thing to do is to protect those people who are willing to lift people out of dark places and who are willing to do something that will not harm their patients. So a question we could ask is, who are the vulnerable? I would say that all of us are vulnerable at various times in our lives, but at some point, we're all going to face death, which is an ultimate vulnerability for all of us. Others will be vulnerable because of disability, others because of mental health. And some of us in times like this are vulnerable because we feel misunderstood or alone, especially in these times of isolation. So there's no shortage of vulnerability in our world. And there's a profound meaning in the fact that there's lots of vulnerability and lots of suffering that we need to alleviate. And as a society, I would say that we need to relearn how to be vulnerable and how to love the vulnerable and depend on each other rather than being self-sufficient. We also need to learn how to suffer again and how to find new ways to relieve suffering. And I would say, you know, this could be a moment of great creativity to find new ways of caring, but instead what our government is pushing is new ways of disposing of people who suffer. And rather than an approach where we cover people's suffering, literally to palliate people, we're abandoning patients because we're giving up the creative process of finding new solutions for them. And believe me, I get it that it's not always easy to have clear-cut solutions for people suffering. I have patients in my nursing home who are on several medications for pain, and they never have full pain relief. But I still visit them weekly, and we try to find ways of lifting their burdens. One of my gals who has intractable pain constantly has a 6 out of 10 pain level of pain on a 0 to 10 scale. And the thing she likes are Cheerios. So I made sure that the dietary staff give her 2 bowls of Cheerios every morning, okay, because it helps her with her pain. And the big thing there, as far as a doctor who cares, is helping to shoulder burdens to make them a little bit lighter. It doesn't mean that we can always eliminate them. But as you all know, with suffering you've had personally, it's always easier to bear suffering when we can shoulder them with other people's help. We shouldn't be surprised when people ask about ending their lives. You know, many of us who are Christian know somebody who asked not for his life. And, you know, in the Garden of Gethsemane, when Jesus says, you know, let this cup pass from me, he was asking for a suffering to pass by him. So we shouldn't be surprised even somebody as strong as Jesus Christ asks for relief of suffering, right? And we should be willing to go to those dark places with people. And before euthanasia was legalized, the whole medical community was finding different solutions for people who felt like the only solution was ending their life. And now it seems that there are very few of us who are willing to search for different solutions. And at this time in our history, we really need to stand courageously to continue to do this as healthcare providers, as families. And just because euthanasia is legal does not mean that people need to be abandoned to euthanasia, which is not a form of care. There's sometimes confusion about what some have talked about, a term that is sometimes used of withdrawing care. But the reality is we never withdraw care from anybody. We sometimes withdraw interventions that are no longer helpful, but we never withdraw care for people, which means effective pain control, addressing distressing symptoms that people have, making sure that families are present. You know, at my nursing home, I've always insisted that families come and are present at the end of people's lives, making sure that they have the appropriate PPE so they can be together in their last moments. And people can detect a caring doctor and a caring institution, which is why some institutions in this country have not had euthanasia requests. And I really, truly believe that one person at a time, we should provide such excellent care that we make euthanasia unthinkable, even though it's legal. I also want to address the physician-patient relationship. The opportunity to protect vulnerable patients still exists in the physician-patient relationship, and it is imperative that we protect that sacred place of trust. When we come with our vulnerabilities to our own physicians, we shouldn't hide our problems. As one person once put it, we should show the pus of our wounds to the doctor, otherwise the doctor won't know what to do to heal it. So in that vulnerability, in that vulnerable moment, we need to ensure that the politicians and elite of our day are not forcing the hands of doctors to give up on tough cases and jump to euthanasia rather than trying to dig for deeper caring solutions. And when talking about protecting conscience, we protect the physician-patient relationship of trust when we do that. Physicians, being in a position of authority, don't want to lord over their patients with their opinions. They want to be a resource to educate their patients who are equal partners in advancing their care. And to be sure, there are times when patients and physicians disagree with each other, but rarely does that ever come to a point of conflict. There are rare times even when a patient of mine has chosen to transfer to another physician because of a difference of opinion or because I wasn't a good fit for them. But the majority of the time, patients who disagree with my advice are willing to discuss it in a friendly manner and find alternative solutions. However, our current federal government, Supreme Court, and many provincial medical colleges are setting up caricatures of people, physicians like ourselves, who don't want to be involved in euthanasia and make it seem, but the reality is that because we don't see it as a compassionate option for our patients, we just want to remove ourselves when patients go down this road. The relationship between the vulnerable patient and the caring physician educator is a place where mutual freedom and trust needs to be built up over time. If a physician feels that he or she will be disciplined if they don't toe the party line, they won't have the freedom to be open and honest in their discussions with their patients. And so again, that relationship needs protection, and C-7 has done nothing to protect that intimate relationship between patient and physician in their vulnerable moments. Patients can no longer count on our medical system to discourage them from falling into despair and thinking their lives aren't worth living. Instead, physicians like us who want to accompany patients in those difficult and dark places might be punished if we don't endorse and move people down the path of MAID without question. Of this is that of patients. And both Dr. Herx and Dr. Coelho mentioned the issue of waiting times. So one dimension that you all know about when it comes to vulnerability is that sometimes it just takes time to heal. People who have had miscarriages or have lost a loved one know that sometimes the only thing that will help them heal is time. And without the time accompanied, that time that's needed, accompanied by a caring physician, it's no wonder that people can fall into despair. And it's a symptom of the fundamental impatience of our culture that we're not giving people enough time. And as soon as someone requests death, the clock starts ticking. And there's nothing creative about that. That's abandonment of the creative process of care. People with disabilities, especially, as Dr. Coelho pointed out, the study on spinal cord injuries, it can take time, up to 2 years, for someone to really accept the reality of their condition. And Bill C-7 would instead give people 90 days, which is an impossible countdown for them to reach, because there are so many specialists who you can't even get to see within 90 days. And so in Canada, it's easier to die than to live. And like Dr. Herx pointed out about the standard of care, the standard of care is going to be killed in Canada with this bill. The next thing relates to diversity. It's pathologic in our society to suggest that some diversity is acceptable, but other diversity is not. So, you know, it would seem that now the diversity of opinions in the medical profession on this topic specifically has now turned into uniformity or groupthink. In 5 short years, those of us who are opposed to euthanasia have become a persecuted minority to be left with little protections for participating in the euthanasia process. And when we are strongly opposed to each other's opinions, this type of peaceful disagreement should still exist in our society, but to do that, everyone's conscience has to be respected. Everybody in medicine, every single doctor has their own lines in the sand and different opinions. Transferring care is totally appropriate when there's not a good fit, say, between a physician and their patient. And disagreements between the two should not be seen as a rights competition or even a conflict. And the government and medical colleges should not micromanage the doctor-patient relationship and leave individuals' freedom intact instead, so that they can choose the fit that's right for them. A point about access. Protecting the physician-patient relationship means that questions of access should not enter this question. Many politicians, ethicists, and observers are suggesting that access is an essential part of the physician-patient relationship, when in reality, access is something guaranteed by the provincial healthcare system. In 2018, Dr. Diane Kelsall, who's with the Canadian Medical Association Journal, wrote, "The responsibility to ensure access to MAID does not rest with the individual physician, but with society. It is the role of provinces to provide an accessible system that does not require a referral. If a particular physician did not think it were good for a patient to pursue a particular course of action, they should not be forced to follow through, but offer alternatives of care." This could include a second opinion, a transfer of care to another doctor, but it should not include a forced referral for something a physician feels is harmful for their patient. Another editor from CMAJ, John Fletcher, wrote in 2015, just prior to legalization of MAID, that Canadian society may soon allow some doctors to redefine their role, but this should not compel the majority of physicians who are not comfortable with this to abandon their convictions. Conscience is not a matter of taste or personal preference. It's a deeply held conviction which prevents us from providing or helping in the process to pursue certain things that are harmful to patients. One final point on autonomy, and I know Dr. Coelho brought this up as well. It is ironic that we're attempting to save all lives, lives at all costs with COVID-19, and protecting vulnerable and elderly in nursing homes is but Bill C-7, on the other hand, is prioritizing their deaths. It blurs the lines and makes it difficult for people who are vulnerable and suffering to choose life when the easier route seems to be to choose death. We can see even with COVID that our high esteem of personal autonomy is that autonomy does not trump all other considerations in medicine. In the COVID era, we see also the creativity and development of vaccines, and that can even revolutionize other areas of vaccine development. If we give up the creative process with those who suffer, we lose the chance to find those new ways of caring. Bill C-7 would make Canada the most eugenic country in the world, putting disabled people and elderly on death row. And there are subtle pressures that both Dr. Herx and Dr. Coelho brought up that will make it make people want to end their lives early rather than giving them the care that they need. People with disabilities are especially vulnerable in Bill C-7, and they deserve special care and attention. Our general rule should be the more vulnerable people should deserve protection in special ways and not be put on death row. So finally, I'd like to really just emphasize that conscience protection is not primarily about protecting myself and my own self-interest, but about protecting my patients. Rather than being an attitude that's focused on myself, the conscience of a physician is a source of insight for a patient who is trying to seek out their own best interest. And in this sense, the pursuit of medicine in the best interest of the patient requires that physicians practice with integrity and not check their moral compass at the door. The therapeutic relationship of trust that I brought up between a patient and a physician is a place where mutual freedom and mutual trust should be built. Physicians ought to attempt to get into their patient's worldview to understand their needs and honestly admit when there's difference of opinion, emphasizing patient's complete freedom. The patient-physician encounter should remain one of the safest places in society, a medical home. Sometimes that safe place involves choosing a physician who is like-minded, and for that we need to respect the diversity of views that Canadians hold. And we need to feel at home with our physicians, and that means we have to have different types of homes in the pluralistic society we live in. The medical home should be a place of creativity where we work together as physicians and patients to improve lives. And again, I would say that every suffering person is an opportunity to find new ways of caring. Thanks so much.
Thank you very much, Dr. Bouchard, for your remarkable presentation. Before we move into the question period tonight, we are going to just take a short pause and we're going to put up a little poll on the screen for you, the participant or the attendees tonight, to ask where you're coming from and give our panelists a chance to catch their breath before we go into our Q&A. So we'll put the poll up and you'll have about a minute to get any more questions in and give everyone a chance to grab a drink of water. I'll be right back. All right, so we have some answers coming in and we should have the results up on the screen in just a minute. There we go. So it seems like most of us are from Quebec, Ontario, and Manitoba, but also scattered throughout the rest of Canada. So thank you to everyone for joining us tonight. It has been a remarkable turnout, and we are so honored to have you with us. We are going to start our question period now. We have received quite a few questions, so we will not be able to get to all of them tonight, but we will do our best to type up a document and send the replies to everyone who is in attendance tonight. So if your question is not answered, don't worry, we will do our best to get a reply to you as soon as possible. So our first question, we're gonna try to put our questions out to all three of the doctors tonight so that they can answer them together or individually and just kind of see where this question period takes us. So our first question tonight is, what people and what groups exactly are pushing for Bill C-7? So doctors, I leave it up to you. Whoever would like to speak first, go ahead.
Leonie, do you want to take this one?
Well, I think there's been some of our disability advocate colleagues who have worded it very well, and they use something called the 4 Ws, the white, worried, well, and wealthy. And I think that is a provocative statement, but I think it's actually a very realistic statement, that it is people who are used to having control over their lives and having access to, what they want, and it becomes an ideology about having control over your own death as well. I think that I like that 4 Ws. It actually makes a lot of sense to me, and it's not the voice of the people who have been made vulnerable by our society and by its discriminatory practices. Those are not the people asking for MAID, but those are the people who are going to be impacted by it. And so what I find truly disgraceful is that our government has not listened to their almost unanimous voices that this is bad medicine, as Dr. Coelho said, but just bad social policy, in fact, more than even bad medicine. And this is not how we should be treating our most vulnerable citizens. Ramona, did you want to add something?
I think just to add to what Leonie said, which is exactly true, that the main lobby group that's been pushing for this and is extremely wealthy as a lobby group, so they can do a lot of marketing, is Dying with Dignity. I would say that every national disability advocacy group, the Canadian Mental Health Association, Indigenous leaders, Black Lives Matter, have all said this bill will be bad for their people and that will endanger their lives. So the contrast is quite striking.
Thank you both for your replies. Our next question is, what can we as Canadians do to help minimize the damage which has been done and will continue to happen as MAID regulations are loosened? So I'll turn that over to all three of you.
Thomas, we can't see you, so would you like to take it?
I'll start and you guys can finish. I think the first thing I would say is that it's one person at a time, one patient at a time. And if you guys out there can bring some of the talking points we discussed tonight and shift the language, certainly you can tell different stories and anecdotes which really help people. But it really is one person at a time that we have to do this right now.
And maybe I'll just add that I think that this bill crosses a line that we will never go back from in Canada. We actually need to stop this bill. Once the toothpaste is out of the tube, can you put it back in? I guess that's the question, right? And I don't think that this was ever the intent of what the Supreme Court had in mind when they put through the Carter decision under these very specific circumstances. I don't think they had in mind that we would open up Pandora's box of assisted suicide for anyone who wants it. With the next steps to progress to mature minors, advanced directives, the Liberal government has made this very clear that this is the first step in a series of steps of expansion for MAID. That's been talked about openly. So I think you actually, to use another analogy, actually need to stop the stone from rolling down the hill and push it back up. So what we need to do is actually put higher fences around this. We're not talking about C-14, we're talking about C-7. We're talking about this expansion that's discriminatory against the rights to life of whole sections of our population. It's wrong.
And I guess the last piece, which is a different, maybe it's more with Thomas about one person at a time, is that the study I was referring to in both BMJ's palliative care journal and the Netherlands Perspective study, which show that the negative social determinants of health are often what lead to people feeling desperate, and that social cohesion is very important and meaning is very important, feeling like one is connected into a community. That's not the solution. The solution is what Leonie said, we need to undo this and kill this bill. But in parallel, to try to decrease the number of victims of wrongful deaths, and just as our social responsibility, we should be making great efforts to reach out to those around us and do socially responsible good acts towards our neighbors.
I think that's, I mean, I did speak very loudly against, I think you have to put the stone back up the hill, but I do think all of those, how we care for one another as human beings and accompanying one another and valuing one another for who we are, is something that we really need to prioritize. And regardless of what happens with this legislation, we need to be on the ground caring for one another and telling people that they're not a burden and that they matter to us. So I think that we should all try to prioritize that in our local communities.
Thank you very much. The next question is focused on palliative care, and it is, what can we do to make palliative care a right for all Canadians? What steps can we take?
I'll start with that one. So I think I brought this up twice in my talk, and I've been thinking a lot about this over many years around policies that we need to move forward in Canada to make palliative care a reality. And I think the most important one that we can do right now is make palliative care, as well as other supports needed for living, disability supports, and home care, a right under the Canada Health Act. That makes it obligatory to fund and make it accessible, and it holds the provincial governments accountable for how they're spending their healthcare dollars. And then we need to be evaluating and holding the provinces accountable to improving the standards of care and showing how access has been improved. So those are some really important ways. The other thing we need to do is make core competencies in palliative approach to care mandatory for all healthcare professionals training programs. And we're working on that right now within the National Palliative Care Framework to look at, everyone needs to have a basic approach to palliative care, whether you're a nurse, a social worker, or a doctor. And you need to understand what palliative care is, most importantly. But the issue is we have this great National Palliative Care Framework, but the funding and the reality to move that forward has just been lip service. There's no funding. So the government has this great framework, but we're not able to do anything with it because no money has been dedicated. So I think really the best way is to lobby the government that they need to make it the same equal rights as MAID, that it needs to be funded and accessible.
Thank you very much, Dr. Herx. Our next question is sort of going off that, and it's, do you have any recommendations to ensure that MAID is not equated with palliative care?
Yeah, so exactly to build off that, part of the problem is that people don't understand what palliative care is. And as I mentioned earlier in my remarks, that it has been, there's a lot of myths and misunderstandings about it. So making sure that we have education on palliative care embedded in all training programs. But beyond that, we actually need public education. We need to make sure that we're myth busting and engaging the public in a dialogue around what it is and how it's different than MAID. There's no reason to be anti-MAID, but it's very interesting in our current Canadian climate that by us speaking up and saying, this is what palliative care does, and this is our unique expertise and why we went into providing this type of care for patients, we are being seen as being anti-MAID. It's so interesting to me that that has been this cultural phenomenon, that if you're not cheering for MAID, you're opposed to MAID. And really, we're just trying to say, this is our unique skill set of what we have to offer. And this is how it's different than MAID. And if you choose MAID, we still want to provide palliative care to you. And so I think making sure that people are clear, and as our joint statement from the Canadian Hospice Palliative Care Association and Canadian Society of Palliative Care Physicians said, these two distinct areas of practice need to be kept separate so that they're not confused. And there's nothing wrong with keeping them separate. You can still access one and access the other, but then patients know what it is that they're getting, and they can choose what's right for them. But they need to be separated, and you need to allow hospices and palliative care units the option of not providing MAID. And it doesn't mean you're blocking access to MAID. You can still get MAID in other settings, but that allows the integrity of palliative care to be provided without invoking fear that already exists in the population that we're going to shorten their lives in palliative care.
Thank you very much. We're going to answer 3 more questions tonight. The questions keep rolling in, and I thank everyone so much for submitting their questions. We will do our best to send everyone answers, but I think we'll just do 3 more for this evening. So the next question is, in the case of Bill C-7, how do we speak to our disabled community when those with disabilities are wanting MAID?
Well, first of all, I would say, I guess you're saying that you have an individual friend who has a disability who wants MAID. I would say that your friend who has a disability is probably lacking some resources to live. And that's where you should start the conversation. Are they suicidal? Are they depressed? Are they lacking home care supports? Is no one cooking meals for them? Can they actually access groceries? As I said, all national advocacy groups for disabled persons have said this is very dangerous for their members. And most studies have shown that even Truchon, if the Truchon case, which is the start of this that Leonie talked about, Truchon chose medical assistance in dying because he was isolated in a long-term care center. He wrote to Jonathan Marchand such a letter saying that he was choosing MAID not because of intolerable pain, not because of intolerable suffering, but because of loneliness and isolation, which wasn't a life. And so if you have a friend who wants MAID, I would suggest that you treat them as someone who is suicidal. The American Society of Suicidology has said that there is no difference between assisted suicide, euthanasia, and suicide, except for perhaps in the terminal context when you're acutely dying if you choose a lethal injection. But from a medical point of view, and if you look at MAID, or what it's called euthanasia in the Netherlands, euthanasia for mental health and disability mirrors suicidality completely, and except that it's here in Canada, for example, a certain amount of people try to commit suicide. Men are more successful, they choose more lethal means, but it is 70% of the population of people who are suicidal are women. And in the Netherlands, it is 70% of the population of the non-dying who choose MAID are women, and they often have the same negative social determinants of health. So I would suggest that your friend is desperate, that you should not see it as a rational request, and that you should try to intervene to help them, just as if a suicidal friend told you that they were thinking of killing themselves.
Can I make a little bit of more of a lighter suggestion? Can you guys hear me? So I've often told nursing home that if I weren't a doctor, I'd be a rec therapist, because I love what the rec therapists do. And recreation, I think, can be estimated when it comes to addressing people who are vulnerable, people who are bored, for example, and a lot of behaviors in dementia, for example, when people are bored and are not seated. So I would say even boredom can be a cause of people looking for a final solution, because they don't have connections, as Dr. Coelho pointed out. So think of recreation, board games or whatever. Maybe there's a video game, or I think could be a good answer too.
We're losing you, Thomas.
Yeah, just turn your screen off, Thomas, and
yeah,
then we'll
maybe
hear you better.
Okay.
Yeah. I would just add.
Can you hear me now?
Yes. Yeah, that's better. I would just add.
Did you get the rec therapy thing? That's the only point.
Yeah, I would just like to add a comment that, you know, usually people, despite the media and the ideology, folks saying a different thing, usually people aren't asking to have their lives ended. It's usually that there's something that's going on in their lives that's a huge source of distress for them. And so I think letting people know and accompanying people that they matter, and understanding what is the underlying source of the distress, and that you'll be there for them no matter what, that is a huge thing, even in palliative care, that helping people see that they're not a burden is a very big part of what we do in something called dignity conserving care that actually Dr. Harvey Chachanoff developed. So understanding a person in the context of their unique story and what their struggles are, just even listening to a person can really already help someone find a new value in themselves.
Thank you very much. And building off of that and talking about burdens is the next question, which is, how do doctors typically deal with terminally ill patients when the patients themselves also feel that their condition is an increasing burden to their caregiver, or feel like they are in the way of their caregivers living a normal life? Hence, they may consider MAID as a way to return the favor or repay the kindness to their loved ones.
I don't mind starting that, and then if Ramona or Thomas want to jump on. So first, facilitating a conversation, of course, to understand what are the particular difficulties that the person is worried they're a burden for. And sometimes it's complete demoralization that you're used to being the breadwinner or the caregiver in a particular family, and now you've lost that role. It may be that you're worried that your son or daughter who's got a busy family and a busy career, that you might take away from the work that they need to do to provide for their family. But most of the time, this can be worked through by facilitating a conversation with the family, because it's usually a person's own fears that an anxiety that cause them to think that they're a burden, when that's not actually the way their community of support and their family sees them. So sometimes I even use an analogy with my patients, like if a family had a toddler or a young child who is dependent on their family for all their care needs, like changing their bum, preparing their food, and would anyone ever say, oh my gosh, that child is such a burden? And if they did, you would think there was something wrong with them. And why is it that when someone becomes ill or has a change in their circumstances, has a disability, or is more frail and approaching the end of their life, that all of a sudden their value changes because they can't do things independently for themselves, when we don't have that same perception in another stage of life? And so I like to talk about it in terms of stages of life, and getting help from someone doesn't mean that you're a burden. And we should equally think that's crazy, just like we would think caring for a young child, to think that that was a burden is totally crazy. And so I think just, opening that door to those conversations, that at some point in our lives, we all need help. And that doesn't take away the value of us as a person, or our dignity, which is inherent to the person that we are. And most often having those conversations are very helpful for families and change people's perspective, which is usually about the way they're seeing themselves, not about how their family feels about them. So I'm sure Ramona or Thomas could have lots of good things to add as well.
All right, I just very quickly would add that sometimes caregiver burnout is a real issue. And that speaks again to social cohesion. That when someone has a new role that they're not used to, first of all, there'll be time to adjust. Two, they need support from those around them. And also, the more that a community is integrated, then the less the chances of someone burning out will be.
I'll just make one last comment about healthcare aides. Besides rec therapists, healthcare aides are my heroes, but I couldn't be a healthcare aide myself because it's so difficult. Being able to relieve the burden of people who have caregiver burnout is huge. And when you see families who are finally able to get their loved one into a care home that they're really comfortable with, and they can see that people love their loved one, it's such a relief to them. And so really opening it up so that people don't think that they are the only ones that need to provide that care, but that there are other people who are willing to love their loved one. That's an amazing thing and points to social cohesion that Dr. Coelho pointed out. So hug a healthcare aide near you when COVID is done.
Thank you. Our final question for tonight is one of action. What can anyone who has been inspired by your presentations do? What actions can be taken now?
We're all in a very dark space right now. Leonie, do you want to answer that question?
Go for it, Ramona.
I think you should answer the question.
I mean, it's difficult, right? We're in our final days of the debate of the C-7 legislation. It's never too late to call your MP. I think we need to start lobbying at a provincial level now as well around the rights for healthcare professionals to be able to practice according to their conscience so that we can create safe spaces for patients who don't want to have doctors who tell them they're better off dead, who want to be able to go to a place where they're not going to be worried that they're going to have their life shortened. I think those are very important things that we can advocate for on a provincial level for sure. But I think we need to work together as all different kinds of grassroots organizations and come together with those who are going to be most impacted by this bill, in particular our brothers and sisters with disabilities and populations that are underserved, and come together and unite our voices to, against the government.
I think I'll just summarize in case people don't know that today, so the Senate added, so this bill will allow people with terminal illness to die, or not even terminal illness, but reasonably foreseeable death the same day that they request it, that it will allow people with disability and illness to die within 90 days. The Senate has added a sunset clause which will come into effect in 2 years, as the Liberals have decided, for people with mood disorders or mental health issues to die by lethal injection. And today in the House, it seems that the Bloc and the Liberals together are going to vote this bill through. So as Leonie said, for this bill, I think that we can just try to lobby our MPs as aggressively as we can. It's a bit late, but Liberals and Bloc need to hear how dangerous this bill is. And all your MPs, because it might affect the final vote.
I just reiterate what those fine ladies said.
I think we've possibly lost Dr. Bouchard. I would like to conclude this evening by thanking each of you for joining us tonight. We had almost 300 people on the lecture tonight, and that was remarkable. Thank you for being here with us. And a special thank you to our presenters. for sharing their experiences, ideas, and inspiring us. We hope that we'll see you back here tomorrow evening for the second night of our lecture. But for now, good night and thank you.
Thank you.